So, have you ever wondered why someone experiencing heart trouble, like during a heart attack, often feels this sudden, sharp pain shooting right down their left arm? I mean, it sounds totally counterintuitive, right? Why on earth would a problem happening inside your chest wall manifest all the way down your limb? Well, the surprising answer to that medical mystery actually lies hidden within a very specific and deeply fascinating set of chest nerves. Welcome to this explainer on the anatomical journey of the intercostal nerves. I absolutely love unpacking topics like this, where we can take a highly complex textbook concept and really map it out visually. Today, we're going to trace a spatial journey. We'll start outward from the very center of your nervous system, the spinal cord, go straight into the architecture of your rib cage, and ultimately dive into some high-stakes clinical realities that doctors are dealing with every single day. Here's our quick roadmap for the explainer. First, we'll meet the intercostal nerves. Second, we'll look at typical versus atypical types. Third, we'll go inside the costal groove. And fourth, we'll wrap up with real-world clinical applications. All right, let's jump right into Section 1, Meet the Intercostal Nerves. So, what are they exactly? The intercostal nerves are formally defined as the anterior primary rami of the upper 11 thoracic spinal nerves. That's T1 through T11. Basically, as soon as your thoracic spinal nerves leave the intervertebral foramina in your spine, they split. The anterior, or front-facing, branches of those first 11 slide right into the spaces between your ribs. Now, you might be thinking, wait, what about the 12th thoracic nerve? Well, because it runs below the 12th rib, it's left the thorax entirely, so it's actually termed the subcostal nerve. But what makes these T1 to T11 nerves so incredibly unique is their segmental character. Unlike the nerves in your neck or your lower back that all tangle together to form these massive, messy plexuses, the intercostal nerves stay incredibly disciplined. Each one takes its own dedicated, isolated path through the chest wall. Let's actually trace that disciplined pathway. Follow the nerve as it exits the spinal cord here. Notice how it turns laterally, sneaking right behind that chain of sympathetic ganglia, those little circular nodes, before making its grand entrance into the intercostal space, right between the parietal pleura and the posterior intercostal membrane. It's a highly specific, very tight squeeze, but this perfectly captures that initial journey from the central nervous system out toward the rib cage. Moving right along to Section 2, Typical versus Atypical Types. As it turns out, the body uses these intercostal nerves quite differently depending on exactly where they're located. On one hand, we have our baseline, the typical nerves. These are the 3rd through the 6th intercostal nerves. We call them typical because, well, they're completely obedient. They remain exclusively confined to their own intercostal spaces, supplying the chest wall and absolutely nothing else. But then we have the atypical nerves, the 1st, 2nd, and the 7th through the 11th. These guys break all the rules by extending way beyond the thoracic wall. For instance, the 7th through 11th nerves literally leave their rib spaces entirely to become what we call thoracoabdominal nerves. They extend all the way downward to supply the muscles and skin of your interior abdominal wall. Now let's shrink down and zoom in for Section 3, Inside the Costal Groove. Now, the absolutely crucial point here is that these nerves do not travel alone. They travel with blood vessels and what's known as a neurovascular bundle, and they park themselves within a tiny depression on the underside of each rib called the costal groove. The arrangement here is incredibly consistent and absolutely vital to memorize. From top to bottom, highest in the groove to lowest, you have the intercostal vein, then the intercostal artery, and at the very bottom, the intercostal nerve, V-A-N. The VAN mnemonic. It is a fundamental, easy-to-remember cheat code for understanding exactly how the body organizes this groove. But the VAN bundle doesn't just float around freely in that groove. It is highly protected. The neurovascular bundle is safely sandwiched between 2 very specific muscle layers in your chest, the internal intercostal muscle and the innermost intercostal muscle, which is also known as the intercostalis intimus. This gives us a crystal clear mental map. Think about it. If you were to push a pin straight through your chest wall between your ribs, you'd pierce skin, fascia, the external intercostal muscle, the internal intercostal muscle. Then you'd hit that VAN bundle before finally hitting the innermost intercostal muscle and the lung lining. It's literally an anatomical sandwich. As that typical nerve travels outward in its muscular sandwich, it's got a lot of work to do, dividing into these 5 distinct branches. First up, the rami communicantes. These are the communication lines connecting the nerve back to the sympathetic trunk. Second, the muscular branches, distributing signals to the muscles that actively help you breathe. Third, the collateral branch, which actually drops down to run along the upper border of the rib below it. And finally, the lateral and anterior cutaneous branches. These pierce straight through the muscle and out to your skin, providing the physical sensation of touch and pain for the sides and front of your chest. It is just a remarkably efficient distribution system. Which brings us to the so what in Section 4, real-world clinical applications. It is pretty fascinating how disease perfectly exploits the anatomy we just learned. Take a condition related to tuberculosis of the spine, known as Pott's disease. When an infection creates a pocket of pus, a cold abscess at the vertebrae, that fluid has to go somewhere. Because of the tough fascia and bone blocking it, the path of least resistance is to track precisely along that neurovascular plane we just mapped out. The pus literally follows the intercostal nerve outward, and it will emerge on the body wall at 3 very specific sites where those cutaneous branches pierce the muscle: lateral to the erector spine in the back, right at the mid-axillary line on the side, or just lateral to the sternum in the front. The anatomy strictly dictates the exact path of the disease. We see a very similar exploitation of anatomy with herpes zoster, which most of us know as shingles. This virus actually lies dormant right there in the thoracic spinal ganglia. When it reactivates, it inflames the intercostal nerve, sending severe, sharp root pain and blister-like cutaneous vesicles shooting out across the chest. But here is the incredible part. Because the intercostal nerves are so strictly isolated to their specific rib spaces, remember, they don't form those messy plexuses, the rash of shingles will perfectly paint a stripe across the patient's torso that matches the exact dermatomal pathway of that single infected nerve. It's a painful yet visually stunning confirmation of the nerve's isolated route. Of course, understanding this anatomy is also about preventing harm, which brings that van concept back into brilliant focus. If a surgeon or paramedic needs to insert a needle or a chest tube into the intercostal space, say to drain fluid or air in an emergency, where exactly do they place it? Well, they know the vein, artery, and nerve are hiding in the costal groove on the underside or lower border of the rib above. Therefore, the life-saving logic dictates that the needle must be inserted just above the upper border of the rib below. By hugging the top of the lower rib, they completely bypass that dangerous neurovascular bundle hanging above them. And this brings us perfectly back to the question we asked at the very beginning of this explainer. Why does heart trouble refer pain to your arm? It all comes down to the second intercostal nerve. As we discussed earlier, the second is an atypical nerve. Its lateral cutaneous branch is actually called the intercostobrachial nerve. So instead of staying on the chest, this specific branch crosses the armpit to supply the skin on the medial side of your upper arm. When a patient has coronary arterial disease or ischemia, the pain signals travel up sympathetic fibers to the upper thoracic spinal cord, which is exactly where the second intercostal nerve originates. The central nervous system gets confused by this shared switchboard. Suddenly, the brain perceives the heart's distress as a sharp pain radiating right down the exact pathway of that intercostobrachial nerve into the arm. It is a stunning reminder of the body's vast interconnectedness. The next time you feel a twinge in your ribs or an ache in your arm, I want you to picture those delicate, disciplined intercostal nerves working silently behind the scenes. What other incredible connections might be hiding right under your skin?